Now I request the next speaker, Dr. Arya, to present her talk on Vergence eye movements. Dr. Arya is the Assistant Professor of Ophthalmology from Regional Institute of Ophthalmology, Trivandrum. Over to you.
Thank you, madam. At the outset, let me thank the KSOS and especially Dr. Naina Jabin Haidar, madam, for giving me such an opportunity today to speak about Vergence. So what is Vergence? Vergence eye movements are where your eyes move in opposite direction, or these are disconjugate movements. In versions, you know, your both eyes move in the same direction. So vergence can be convergence and divergence. So what is the stimulus for this vergence movements? There are two primary stimulus to the disjuncting eye movements. One is the disparity between the location of images in the two retina, which produce diplopia, and that leads to fusional vergence movements. And second one is the retinal blur or the defocused images. And this also leads to a loss of sharpness of the perceived images and accommodation-linked vergence movements. So this is a basic stimulus for your vergence eye movements. Now, convergence is a disjugate movement in which both the eyes rotate inwards so that the lines of sight intersect in front of the eyes as shown in the picture, and this allows bifoveal single vision to be maintained at a fixated distance. So convergence remains more or less same throughout our life, and it doesn't deteriorate like our accommodation. So power of convergence can be increased by exercises. So what is the angle of convergence? As denoted in the picture, you can see it is an angle that is formed between the primary lines of sight during convergence, and 1 meter angle convergence is exerted by each eye when eyes are directed to an object at a distance of 1 meter of the meridian line between the two eyes. And now coming to the types of convergence, it can be voluntary as well as reflex. And there are 4 types of reflex. One is tonic. As we know, it is a convergence that results from the inherent innervational tone of the extraocular muscle when the patient is awake. And this is independent of fusion or object proximity, and this is the most prominent in childhood. And the tonic convergence decreases with age. Second is your fusional component. It's an important mechanism for maintaining bifoveal single vision, and the normal fusional convergence amplitude for distance is around 18 and for nearest 35. And it helps to control your exophoria. And this fusional convergence decreases by fatigue or illness. And next is the accommodative convergence. It occurs when the eyes accommodate. And that is a part of the triad of the synkinetic near reflex complex. And last one is the proximal convergence. It is induced by the proximity of the object of regard. So these are the 4 types of reflex convergence types. Now next we have to know certain terms regarding convergence. One is the near point of convergence. That is the nearest point at which the patient can see as single. And far point of convergence is where when your eyes are at rest. When your eyes are at rest, it is in a slight divergence, and hence the far point of convergence will be lying somewhere behind your eyes. And next is the range of convergence. That is the difference between NPC and FPC, and amplitude of convergence. That's the difference when a patient looks at the nearest point where he sees as single and the far. Now this is an instrument by which we measure convergence. As you all know, this is a RAF ruler, the Royal Air Force ruler, from which we can know the near point of convergence. So it has got 4 boxes. The one is the reduced Snellen's chart. The second one is a section of the general post office telephone directory. Third one is C is the Times Roman typeface, and fourth is a dot on a line. So there are 4 things on this RAF ruler, and for measuring the NPC, we use a last one, that is a line. Now, this is how you measure the near point of convergence using the RAF ruler. You explain to the patient what you intend to measure. You move the box near to the eye of the patient and ask her up to what point you can see it as single. When she sees a double, then that is the near point of convergence, and it is indicated in the RAF ruler. From that, we can notice what is the near point of convergence. Normal NPC is 7 centimeters. Closer than 5 centimeters is excessive, and more than 10 centimeters is considered as defective. Now, how do you measure the how do you measure the amplitude of convergence? How do you know that? Now we have seen how you measure the near point of convergence. Coming to how you measure the amplitude, you have got two methods. You can calculate it with your prism bar or the synoptophore method. So this is a video which shows how you can measure the positive fusional vergence, that is, given accommodative target, ask the patient to look at that, and using the prisms, first with base out, you increase the power of the prism, you ask the patient to concentrate on your target and ask when she is seeing it as double. In the video you can see I'm increasing the power of the prism, and at a particular point the patient will be saying she is seeing it as double, and that is a break point. Now you reduce the power of the prism and come to the recovery point also. For calculating the negative fusional vergence, the same principle only, but you just change the direction of the prism. That is, in the first one we saw it is base out, now you keep it as base in. So you can measure the negative fusional vergence. In the video you can see I have changed the direction of prism. So what are the anomalies of convergence? First is convergence insufficiency, which we commonly find in our clinics, convergence paralysis and convergence spasm. And convergence insufficiency can be primary or due to refractive errors, presbyopia, or consecutive convergence insufficiency. And how can we diagnose it? The main complaint of the patient will be asthenopic symptoms, and these are the methods by which you diagnose it. And treatment can be optical and orthooptic. And one is advancement exercise, which is easier to say and easier to perform at home also. You ask the child to hold the target at a distance, come to a near point where the child can see it as single at the maximum near point, and ask the mother to monitor this exercise, because otherwise the child will be doing in some fancies, he'll be moving at his own will. So teach the parent nicely how you have to do the exercise, and ensure the parent that the parent supervises this during the initial period. This is the stereogram card test. These are strings which it is available online also, but this is done in an office method. This is the diploscope. And these are the other associations of convergence insufficiency, neurological diseases, that is Parkinson's disease, progressive supranuclear palsy, and the following conditions. Thank you.
Hello. Thank you, Dr.